In terms of lumbar puncture, it's a very important question. It needs to be performed preferably before starting antibiotics in any case where the likelihood of sepsis is high. So if you're very strongly thinking it's sepsis, the baby comes with septic shock or anything, if the baby is clinically stable enough to tolerate the lumbar puncture, you would do the lumbar puncture before the antibiotics is started. In the early onset sepsis, the likelihood of meningitis is lower. Most of us either do it if the strong correlation like maternal chorioamnionitis or the baby has fever, or if the culture comes positive. The inflammatory marker going high, you can decide according to the clinical situation. If there is meconium aspiration pneumonia and the CRP is going high, you don't necessarily need to do a lumbar puncture immediately because inflammation from the meconium itself causes the CRP to go high. But you have to individualize your decision and document your plan clearly, and also inform the parents that if this is the scenario, we'll be doing a lumbar puncture so they are mentally prepared. In late onset sepsis, the likelihood of meningitis is higher, about 30% or so. So you would consider it as part of the sepsis screen. And if the baby is clinically unstable and you don't do it early, you do it when the culture report comes and the baby is clinically stable. So in coagulase negative staph, I mean, usually meningitis is rare. So unless you have neurological symptoms, you may not do a lumbar puncture and you may decide to stop the antibiotics by 7 to 10 days if the baby is clinically well. But remember that in the premature babies with symptomatic chronic sepsis, the bacteria is quite difficult to eradicate unless you have removed the central line and you have given vancomycin treatment appropriately. If a baby has fever or rash, like we discussed in the last lecture, herpes PCR in the CSF be done as well. And we have to treat the baby with acyclovir while we wait for the PCR results. The question comes up in situations where you don't have the PCR availability. It becomes challenging because you're starting the treatment and you don't know how to stop it. So, I mean, it's a challenging situation in the resource limited places where you don't have herpes PCR. We have a high CRP, positive blood culture, or poor clinical response, and neurological concerns on examination. Any of these would need a lumbar puncture. Whether you do lumbar puncture in babies with asphyxia or seizures depends on the main focus. If you're thinking strongly in terms of infection, you definitely consider a lumbar puncture in those cases as well, because even sepsis can be a cause of asphyxia. We look at the CSF glucose, protein, cell count, as well as a gram stain and culture. And as I said, the herpes PCR can be done. You have rapid PCR detecting different bacteria in addition to the viral PCR. So you can look at that as a guide to your antibiotics as well. So the CSF findings are if the WBC is more than 32, especially if the polymorph more than 60%. So you don't get zero polymorphs in newborns. You allow up to 5 to 6 polymorphs, for example. But if the cell count is high and the polymorph is high, it becomes more clear cut. The glucose is usually less than 50 to 75% of the serum level, and protein is more than 150. If you have organisms on the gram stain, it correlates, and obviously you consider the PCR if possible. So this is the table from the NNF guideline. You have the, printout or the PDF version of the slides that will be shared. So you can go through that. But remember that the protein range is higher for the premature babies. And in babies, the premature babies with the intraventricular hemorrhage or ventriculomegaly, the sugar drops. So we call it hypoglycemia. That's quite common in these babies, and that becomes a poor correlator. So the cell count in a traumatic LP and the protein content in a traumatic LP. If the CSF is blood stained, the protein content is going to go up. And correction with the red cell count is not very easy as well. I mean, nowadays people suggest you go by the uncorrected one and go by the clinical risk and the culture reports in such cases. The repeat lumbar puncture is not routinely needed. If the baby is clinically responding, you treat according to the duration that would be recommended. If your CSF is negative and blood culture is negative, you would go by the inflammatory marker response and the clinical response for the duration of treatment. We